All right, we'll get started, and thank you all for listening to this presentation for the GAP, MASLD, and MASH Community Network. We're going to talk about non-invasive testing and different options we have for our patients. My name is Erin Tanner. I work for Gastro Health in Birmingham, Alabama. I've worked for them for 14 years and do general gastroenterology, which does include some hepatology as well as IBD. Here's the QR code to register for this meeting. And here is a QR code to get some more information about the MASLD and MASH Community Network regarding disease state as well as Resdifra. We're going to start off by talking about a case study. We have Albert. He is a 65-year-old Hispanic male who has been referred for elevated liver enzymes. He has also had an abdominal ultrasound that showed fatty liver. Over to the right here, you can see his laboratory values. His hemoglobin A1C is elevated, and he has a 3-year history of a known elevated ALT. He has been worked up for other chronic liver disease issues, and his hepatitis panel and liver serologies have been negative. He does not drink alcohol. He has type 2 diabetes, hypertension, hyperlipidemia. So with this information, we can diagnose him with metabolic associated steatotic liver disease. We'll talk about some non-invasive testing that we can do for our patients. Let's start out with some imaging biomarkers here. First of all, you have ultrasound quantitative techniques, and this includes ultrasound elastography to look for liver fat. You also have 2 MRI options. You have the MRS, which is the magnetic resonance spectroscopy, as well as MRI-PDFF, which is MRI using a proton density fat fraction. And then you have your CAP, which is controlled attenuation parameter, which is FibroScan. All of these techniques look for fat in the liver. Other imaging biomarkers that look for liver stiffness or fibrosis include SWE, which is shear wave elastography. You have ARFI, acoustic radiation force impulse, which is also a type of elastography. You have VCTE, vibration controlled transient elastography, and then you have MRI elastography. So as you can see, the imaging biomarkers at the top look for liver fat. The ones at the bottom look for liver stiffness or fibrosis. Now we'll talk about some lab markers that we can use to assess for hepatic fibrosis. You have your FIB-4 test, which stands for fibrosis 4. That's a laboratory. You gather some laboratory values, put it into a calculator. It can tell you the risk of liver fibrosis. Other lab predictions, non-alcoholic fatty liver disease fibrosis score, and then APRI, the AST to platelet ratio index. These are calculators to use to assess for potential hepatic fibrosis. We also have some proprietary serum markers for hepatic fibrosis, the ProC3, which is type 3 collagen formation, the ELF, enhanced liver fibrosis. We also have FibroSpect and Fibrometer. Another one is FibroSure. These are all laboratory tests you can order to assess for hepatic fibrosis risk. We also have some combined rules that combine imaging biomarkers as well as serologic biomarkers. FAST, which stands for FibroScan and AST. You have the MEFIB, which is the MRE and FIB-4. And then you have MAST, which is MRI and AST. These are combined biomarkers to assess for hepatic fibrosis risk. FIB4, this is a very common calculator that is used to predict hepatic fibrosis. It combines the patient's age, AST level, platelet count, and ALT level. If you have a low FIB4 score, this exhibits a high negative predictive value for excluding advanced fibrosis in our patients. So if you have a low FIB4 score, you can be confident that the risk of fibrosis is actually low. And then, of course, if you have a high FIB4 score greater than 2.67, this indicates an increased likelihood of advanced fibrosis. And if you do have a high FIB4 score, you should order some other testing to help predict hepatic fibrosis. Again, we have some proprietary serum markers for hepatic fibrosis. A common one used is ELF, enhanced liver fibrosis. This test uses 3 biomarkers that measures the risk of fibrosis, and it has a very good diagnostic accuracy. The 3 markers that are used are the TIMP1, the P3NP, and the hyaluronic acid levels. Again, this is very good diagnostic accuracy in predicting hepatic fibrosis in our patients. Other non-invasive tests used is liver stiffness scores. Stiffness is the ability of an object to resist deformation in response to an applied force. Shear waves travel faster through a stiff liver. So if you have a stiff liver, that increases your predictability of hepatic fibrosis. VCTE, vibration-controlled transient elastography. This is a non-invasive quantification test of 2 biomarkers of the liver within a 10-minute exam. So you have a liver stiffness, VCTE. This is basically ultrasound elastography. And then you have a CAP score, which is FibroScan. It looks for liver fat and is also correlated with a VCTE score to assess your risk of hepatic fibrosis. Both can be used to assess disease severity, and especially in patients that have MASH or any other liver disease or chronic liver disease. There are some considerations to be aware of when talking about VCTE. Basically, these patients have to have 10 valid measurements within 10 minutes. So it's important to know if their IQR score is greater than 12%. IQR is interquartile range to median ratio. So basically, out of all the scores within 10 minutes, you want to know if they're the difference between their third and fourth quartile. You want them to be very similar. Then you have your IQR to median ratio there. You want that to be greater than 30%. All of these factors have a lot to do with the user experience. You know, if you have a new ultrasound technician or a new provider doing the FibroScan, that may affect the accuracy of the scores. You have to have good image quality, and also getting 10-minute measurements in 10 minutes is important. Other considerations, if our patients have significantly elevated transaminases or cholestasis of the liver, or they use excessive alcohol, this can produce a false positive fibrosis score when actually there's a lot of just hepatic inflammation. So those are things to consider when ordering a VCTE. Also, patients have to be fasting for this test. If they have morbid obesity with tremendous intra-abdominal fat, that may also predict false positive fibrosis scores. Again, ascites and liver masses can also hinder these results. MR elastography, this is a MRI technique that assesses shear wave technology to look at hepatic fibrosis. This is a very accurate test. Some considerations or limitations to think about. Of course, BMI, morbid obese patients may make this less accurate if they have hepatic iron overload. Our patients may come with non-MRI compatible devices, claustrophobia. This is an expensive test and is not readily available, but it is highly accurate. This is a table just looking at the different things we talked about. So first of all, you have the FIB4, which is an indirect serum fibrosis marker. Again, it uses the patient's age, their serum AST, ALT levels, as well as their platelet count. Some limitations to think about. It has a very low positive predictive value. So if you get a positive FIB4, certainly you would want to order or consider another non-invasive test to assess for liver fibrosis. It does have minimal data required. These are routine tests checked frequently with a lot of patients. And then there is a high negative predictive value. So if you have a negative FIB4, you can feel confident that the risk of fibrosis is actually low. You have a direct serum fibrosis biomarker. We're going to use the ELF here. This is a send out test. Sometimes this can be costly to patients. It does, however, have a high negative predictive value. So if you're able to get it through LabCorp Quest, it's a good test to consider. And then we have our imaging biomarkers. We have VCTE and MRE. For VCTE, it requires an experienced operator. You have to look at the other confounding aspects there. Is your patient morbidly obese? Are their transaminases tremendously high? Did they use an excessive amount of alcohol? That may present a false positive test. And then as far as strengths go with VCTE, it is point of care. You can do this with abdominal ultrasound or FibroScan right there in your clinic at the bedside. And there is a high negative predictive value. MRE, this is very accurate, highly accurate. There's not many confounders there, but it is costly and is not readily available. But if you have access to it, I think it's a great option. So we'll go back to Albert here. Again, we said and diagnosed him with metabolic associated steatotic liver disease. Here are his lab values here. He has a mildly elevated ALT. His AST is normal, platelets normal. His FIB4 score was 2.22, which was considered to be indeterminate. So what should we do next? You have a little algorithm here to your right. Basically, we need to identify our patients that have 2 or more metabolic risk factors, abdominal obesity, type 2 diabetes, sleep apnea, hypertension. If you have patients like this, then we should at least do a FIB4. Any patient with type 2 diabetes, or if they incidentally have fatty liver on an abdominal imaging exam and they come to us for an unrelated disease state, then we should at least do a FIB4. After you do your FIB4, we can determine if our patients are low risk patients, then do repeat NITs in 2 to 3 years. And then indeterminate patients, we should order a second exam, a VCTE, MRE, and if they are considered moderate risk, consider referring to hepatology for liver biopsy. And then, of course, we want to follow these patients every 2 to 3 years for repeat NITs. High-risk patients refer to hepatology if you don't typically follow patients like that. So for Albert, his FibroScan was considered low risk. So for him, we educated him on lifestyle modifications for fatty liver. We want his metabolic diseases, type 2 diabetes, hypertension, hyperlipidemia to be well managed. And then we're going to follow him every 2 to 3 years to repeat FIB4 as well as any other secondary NIT tests that we feel are indicated. And that's all I have for you.